so I'm Kassie Runsabove. I am White Clay and Cree, so this is always my first cultural sensitivity right here, breaking down barriers. So the federal government gave us the name of our tribe, but before that, we met French settlers way up into Canada where there's the falls, you know, like Great Falls and all the pretty water over there. Well, when we were first coming into contact with each other, our people, you know, we spoke White Clay, or Ainin, and then the French spoke French, so we didn't speak the same language. So we used a lot of sign language. So when we first introduced each other, we were the Falls people. So that was French for big belly. So that's what Gros Ventre means, it's big belly. Some of us fed into that stereotype. But we were very tall people, we were very big people, but we weren't hefty people. So for us to have the name Big Belly is actually very insulting to us. But that's the name of our tribe. So under federal regulation and law, we're Gros Ventre. But a lot of us in our generation, we're starting to change and say we're White Clay. We're educating people, and even our own people, of how we want to be addressed. So, and then I'm Cree. So my dad is from Hayes, Montana. Does anybody know where that is? Lovely old Hayes. It's about 2.5 hours north of here. And then does anybody know where Rocky Boy is? So a lot of Crees are from Rocky Boy. That's where my mom's from. And mostly grew up all over. My dad is a retired CEO of IHS, and then my mom's a retired human resource specialist for IHS. So I got to move all over. I used to live here in Billings and then moved to Wind River Reservation. Does anybody know where Wind River Reservation is in Wyoming? Well, that's the only reservation in Wyoming. And so I lived there for a little bit, and then moved to Fort Belknap and graduated high school from up there, and then moved to Fort Peck for a summer and a half, and lived with my husband there for a little bit, and then lived in Havre for a while. That's where we had our son. Then we moved back down here to Billings. So kind of moved all over, been very interactive with other tribes, and then went to Riverstone Health, and I was the prevention health specialist there for a while. I worked with the Crow Northern Cheyenne Indians. So that was a little bit of background of who I am, but the objectives today is we're going to define cultural sensitivity and provide the description of American Indian children and families, and describe at least 2 barriers into implementing and create some strategies around that. That's what we're going to talk about today. And I'm really interactive, so anytime you guys have a question, please just ask. So why culturally competent healthcare? So how many people do we have that are working in healthcare or like a social service background? So we work with a lot of patients, and again, American Indian patients, we have a different demographic, but again, we're talking about patients in general, right? So individuals that come in for care. So we need to be more responsive to the needs of the client, increase the patient's satisfaction, and decrease inappropriate characteristics and quality of care. And close the gaps in health status across diverse populations, so decrease the health disparities across our population. Components of culturally competent healthcare. And competent is a really heavy word. It makes it sound like you are the expert in it. But the reason why I showed that is because we've talked about awareness for many years. We talked about sensitivity for many years. So now I'm kind of raising that bar and trying for people to feel like they can be competent in the work that they do with a diverse population. So culturally diverse staff, it would be nice if there's a culturally diverse staff, if it's possible in the community that you serve, and also within the skill set that you have to have working in the field that you're. So again, do we have Native doctors? I'm happy to say at St. B's we have 3 Native physicians. We have several Native CNAs, we have several nurses that are Native, we have rad techs, we have quite a bit of, a good population there at St. B's, and I know down the street too at L.H.'s Clinic is very diverse, so it's really nice to see that. And again, our boards, right? When we think about our facilities, we have to think about the boards. So we look at our health board, you know, the St. B's board, things like that, that's not as diverse as the actual people working there, but that's something that we're gonna work on. That's something that we want to change. So, and that comes from the people that are there. So, to have providers or translators who speak the client's language, we're really lucky. Most of our natives in this area speak English, or else at least have family members that could speak English for them. We do have some that end up coming here because they're traveling, regardless if they're native or not. So we do have translators available. And training providers about culture and language of the people they are servicing. I get really, it gets too bogged down if we say, oh, Crow people act like this, Northern Cheyenne people are like this, and White Clay people are like this, and that Cree people are like that. It's impossible, right? And so sometimes it can be very intimidating for a provider if this is their first time in Montana. Because then we assume everybody's from Montana, right? And we assume that you should know everything about Montana and think how Montana people think. So it's really hard for our providers because they've actually been kind of cultured pretty well because they've gone to bigger cities. They're used to being around a lot of different types of people. And you come to a small town and the receptionist is somebody that went to high school with a client and they have a judgment of that person. Something happened in high school, she stole somebody's boyfriend, and, you know, she has a sour look on her face. So then that patient interaction with that receptionist might be kind of bad. Now you go into the nurse is just having a bad day. She spilled coffee on her shirt she liked, and she was trying to go out to dinner after, and kind of messed up the plan, so she's mad because she spilled coffee on her shirt. And it comes off as that she's mad at everybody. The patient is already put off at the point of entry, and now they feel like they shouldn't be there. And then the provider comes in and says, all right, let's talk about your stools and what color are they? And, you know, it's kind of overwhelming. So it's, you know, we have to think about the whole concept of healthcare from the parking lot all the way to the doctor's office. There's a lot of people interacting at that point. So when we're talking about cultural competency, we don't just want to talk to administration or our providers or our nurses. We also want to bring in our janitors, our receptionists, people that will interact with our patients all the way around. And the signage, it should be, you know, welcoming. And, you know, when you walk into a facility, if everybody's face doesn't look like yours, you already don't feel welcome. So when you're working with your marketing department or anybody that's doing social media, it's really helpful if you're including the whole group. And then culturally specific healthcare settings when feasible. So on this one, this is a little bit harder because we're all so different. So sometimes, you know, I kind of make fun of our dream catchers because, oh, if there's a dream catcher, then, oh, they're native, or, oh, they got it, they know. You know? They know. And I make fun, but really, it's sometimes you feel like what you're putting on the wall is welcoming to people, but sometimes it might be like, they don't really know us, and I really don't want to open up. And then on the other side of it, our hospice provider, so she gets to sit down with our families quite a bit. And she talks about the patient, so the patient isn't there, but the family gets to come in. And she asked a question, she said, should I have like sweetgrass and sage, you know, on my table, or what can I do to make it more welcoming to our patients? I am raised traditionally and practice my spirituality quite a bit. So to me, I said, yes, that would help me feel more comfortable. But then I said, but let me ask a few people before I say absolutely, go and put sweetgrass on your table. So I went and asked a few of my family members, and then I asked some of my friends that work in town and also work with their Native American population. And they all said, no, I wouldn't feel comfortable because I'm Catholic. I wouldn't feel comfortable because I'm Christian. I wouldn't feel comfortable because I don't believe in any of it at all. So that made me realize you can't just group people. It even made me realize that you can't just assume that everybody is going to believe in the same exact thing. So really, to make somebody more comfortable, maybe it may not be a picture on the wall, but to say, what do you prefer? What would help you be more comfortable? So maybe in the drawer that you have all the different types of things that you would have for any other religious background. to help them feel more comfortable in talking about a situation. Culturally competent healthcare. When patients do not understand what their healthcare providers are telling them, and providers either do not speak the client's language or insensitive to cultural differences, the quality of healthcare can be compromised. So when a patient comes in and they don't understand, and you're telling them in a way that they should understand because you're bringing it down a little bit. But this is what I encountered when I was at Riverstone when our women were diagnosed with cancer. Regardless of your background, when you hear cancer, you shut down. So you don't hear anything after that. But if you know and understand that the culture of cancer, or the culture of the reaction to cancer, can be very devastating, that you can say, I'll sit here with you for a little bit until we can talk about this. To make sure that that time frame is allowable for you because of that diagnosis. So sometimes we think of culture too as a specific, like Native American or being white clay, but really it's about the culture of your healthcare system, the culture of care that you provide, and then the culture that you work in, right? Because emergency services is totally different than inpatient. Emergency is really fast and quick, and you're in and out, and they're used to going 100 miles an hour, and that's what they like. And you have inpatient, and then you have surgery, and then you have some doctors that never interact with their patients. You have some of them that, while they're in surgery, I don't ever talk to my patients. They never have to talk to them. So sometimes we have to just bring it down and say, well, really, who are we talking about and what are we doing? Not everything is exactly the same. And what can we do when we're training or educating or working with our clients? What kind of language are they speaking? They could be very intelligent. You know, when we talk about the languages, our language was taken away from us from the very beginning. And so it's amazing that some of us speak our native language. I don't speak mine. But we have a lot of fluent Crow speakers and fluent Northern Cheyenne speakers. And I always think if somebody can speak one or two or more languages, they're intelligent, right? So why do we make assumptions that we have to talk less than to our native patients? Just a thought. Just a thought that I've been thinking about when we talk about cultural sensitivity. When we have bilingual speakers, we should hold them up a little bit higher. Or at least treat them as, you know, an intelligent person. So those are just different things and how we can talk to our patients. Respecting one's beliefs, values, culture, practices, and differences. The reason why I underlined respecting, because respecting is very hard. It's really, like I said, competency. It's an easy word to put up there, but it's not an easy word to do. Respecting is an easy word to put up there, an easy word to say, but it's very hard to do. Because us as professionals, right, when somebody comes into our office or our area and they're being disrespectful to us, it's hard to be respectful back. That's customer service. That's not cultural sensitivity. That's when your customer service comes in and maybe they don't want to talk about this right now if they're coming in for drug and alcohol addiction counseling or parenting counseling or something. You know, I myself as a parent is already hard enough for my mom to tell me what to do. I couldn't understand if your kids were taken away and then now you have to take all these other classes and then people are asking you all these other things. You know, if they come in a little bit abrasive, I'm not saying it's normal or right, but just understand they're in a difficult spot. I know I'm preaching to the choir if you're working in social services. But with the situation, I would say it's a little bit easier to say, well, on paper, oh, Kassie Runsabove, you know those Runsaboves. They're probably going to come in here and give us some grief because those Runsaboves, I don't know. Then I come in all cheery and say, okay, educate me, tell me what I need to do. And it's a different interaction. So we can't just assume because of their last name that's going to be what you expect. Sometimes it could be a really good outcome. And sometimes it could be really bad. My name used to be Nicholson. My name is Kassie Nicholson. Well, she's probably non-native, probably be easy. Then I come in and dump a whole load of stuff on you, and I need all these resources. Well, I wasn't prepared for this because I thought you were non-native, based off of your name. So we just kind of assume. We do smudging, and we allow different types of ceremonies at the hospital. And I know both hospitals allow smudging, so that's really nice for our patients. But a lot of times, our patients don't know about it because either the nurses don't feel comfortable saying it or they forget. So it's just something that, even in your own office, what can I do to accommodate this family? And even just asking them, so maybe you can't service this patient or this client, but maybe you can help the next one to come in your door. Because we have to remember we only have about 15, 20 minutes with our patient or client. What can we do to impact not just that patient, but the next patients that are going to come in? So history. To really understand our background, not so much our culture, but the background is to understand the history. And this is the United States history. This is our government's history. Because from 1492 it's been documented, but before then it wasn't documented. So this is my family up here. This is my great-great-grandma, my great-grandma. And so this is my family from Rocky Boy. Elizabeth Parker and Cecilia know me. And then this is my grandma right here, my dad's mom. And this is in front of the Mission Catholic Church, the Mission Canyon in Hayes. This is my great-grandma, my great-grandpa. So we were all Grovans, all Cree, so then that's my family. And this is just a picture that I showed to represent what happened in boarding school. Visualization of what they used to say is kill the Indian, save the person. And so that's what they do, cut their hair off, change their clothes. So that was colonization. And historical and generational trauma is what we are seeing today. And that's a whole nother lunch and learn. But that's to really understand our history, is to understand the different things that were placed upon us. So the one thing that I like to talk about in our cultural sensitivity, because I believe culture and spirituality and things like that play hand in hand, is our spirituality was taken away from us until 1956. So freedom of religion didn't apply to us. Our religious activities were taken away until that point, so everything was underground until then.
Can you give us an example?
So our sun dances, they were all done underground. I don't know anything about, like I know our sweats, they were considered like worshiping the devil, like witchcraft, like smudging in public, and our gatherings, they were all outlawed. It's hard to believe. And so the reason why I bring up history is because there was so much rules, laws, and regulation placed on us that inhibited us to be human beings. That inhibited us to be parents to our children because our children were taken away from us. And not every child was taken away, not every child went to boarding school, but just even that one can impact generations. So the reason why I bring up that history is because when you see our Native patients and they're mad, they're upset, then there's another rule, there's another regulation. There's a lot of us that fight the federal government. There's a lot of us that don't believe in it. There's a lot of us that don't respect it. And so I see a lot of change. I see a lot of more people like voting and being a part of things and wanting to be a part of it. But I also see a whole other generation where they say our vote doesn't matter, or our voice doesn't matter, and where I go doesn't reflect who I am, and it's really heartbreaking. And so, and then there was the Indian Relocation Act. So we were placed on reservations, And then in the 50s, that's when the federal government said, oh, well, we put them all here, they're still surviving, what are we gonna do with them? We should teach them how to do a trade or a skill, and then they could come back to the reservation, and then they would have business development on the reservation. So my grandma was a part of that. She went to California, and she was a part of the relocation. And she was like, I can't remember what she did, but she worked at an airport, and she was mapping like where planes landed, so like worked in the aviation stuff, and so they trained her how to do that. Then they sent her back to Rocky Point. There's no airports in Rocky Point. So there was things like that where things just didn't match up. Maybe it was well intended, but it just never followed through. So that's why we may have a little bit of a chip or an assumption on our part where we think, oh, this great program is here to help you, and we're here to help you, now let's lay it out. Well, there's no natives behind it, there's no rhyme or reason to it, but the help is there, and I think the willingness is there, but just the understanding of who you're presenting it to isn't there. And then we have all of the history, and even though there's some of us that don't know our history, there's some of us that don't know or even understand about the federal government or even what our tribes did to even fight being on a reservation or what they did to enact our tribal councils or learn about our legislations. There's some of us that don't know that, but it's instilled in us. That resentment and that hurt is instilled in us. And that's why I said there's a whole another lunch and learn for historical and generational trauma. So this is just a map, and I know that there's some tribes that are not on here. Like we don't have Blackfeet on here, but this was just to show you this is where we were. And back then we didn't have the borders of Mexico or Canada. But this is just a demonstration map to show you kind of where we all used to be. And this is a map to show you where we are now. So that's...
Kassie, on that map before, is most of the population in certain states?
Not really.
Smaller tribes?
Yeah, smaller tribes. Some of them, like what I talk about in mine, because we don't know before 1492. You know, we have theory of what happened before 1492. But I believe there was several different tribes that we never even met or knew about, that their history was lost completely because of when people came over to settle. So that's my own theory, but there, and then the Trail of Tears when everybody was trying to move everybody to Oklahoma. And so that's when a lot of tribes interacted too, and then they all got married, and so, yeah. And then, so here's our reservations today here in Montana. So there's my little tiny reservation up there in Fort Belknap, and then Rocky Boy, where my mom's from. So, there's 3 things you need a pedigree for. Can somebody help me with that? So one of them's a dog, right?
Yeah.
And what's the other one that has a pedigree?
Horses.
Horses. Us guys. We get tracked by our blood quantum. So that's how we get enrolled, and that's how we get to utilize services on the reservation. And so, and the reason why I say that, most of us get to utilize any IHS facility anywhere, as long as you're an enrolled tribal member. Well, if you're Little Shell, you're not federally recognized, but now you're state recognized. So you still don't get to use IHS because IHS is a federal system. And I could go to any IHS facility and receive preventive health care, but when it comes to diagnostic, and then you have to be referred out, and then it's our purchase referred care program, and then so they look through what your ailment is and possibly how much it's going to cost and what type of services you're going to need, and then they'll decide from the administration level, you know, the CFOs, and they'll look at it and say, well, we don't have this in the budget because it's just a preventive thing, so you don't get to go this month or maybe even this year. So then that's why it was really helpful with Medicaid expansion, because then our Native people got to be enrolled into Medicaid or Medicare. And now we don't know what's going to happen, so cross your fingers. But that's just an overview of what happens. And so by the time we see our patients here in town, they're so used to IHS, you know, they get to see somebody that they went to high school with, and then pharmacy right there, it's easy, and then they know when they say labs right down the hall, just go ahead and go get your lab drawn. And that's a facility that we have utilized for years and years, and grandma went there, mom went there, auntie went there. Everybody knows how to navigate within that healthcare system. But then they get referred out and they come to St. V's or Billings Clinic, and I'm sorry, I couldn't even tell you where to go. When somebody says, go get your lab drawn down the hall, and you don't know where you're going. So you're already intimidated, you're already scared. You already don't know how you're gonna pay for it, because the system that you're used to utilizing, that's free. It's covered. So, and that's the other assumption too, that we receive 100% of free health care, and we receive 100% free education, 100% free housing. That's a big stereotype. That's not true. We still have to pay, you know, when we get referred out. So you may get the medical referral, but if you don't get the financial referral, and somebody says, well, you're gonna have to come up with this money, that person's probably not gonna go, and they don't know how to go. And then how are they gonna get there, right? They don't have a vehicle or a car, or maybe they do have a vehicle and car, but they're the sole person that takes care of their family, so who's gonna pick up their kids? So sometimes there's more to the whole story, and just finding out, you know, let's just do what we can to help you. And this is all the tribes within the United States. So you can see over here, there's nobody left, right? Those are the small, the little pink, I don't know if you guys can tell, it's just the little tiny pink dots. So those aren't necessarily reservations, but they might have like a community center where their people can go. And then you come farther over and you can see this is how settlement happened, right? And by the time I got over here, and then what's amazing about Alaska is they only have one reservation, but what happened with them is because they got, they were in the Union later than we were, so in the 1950s they became, so nobody was trying to get up to Alaska, right? Nobody said, hey, there's land up in Alaska, let's go up there. So they really got to keep a lot of their heritage and culture. I got to go up there this past October, and it was amazing, because I was on the plane ride, and I said, I really hope I get to meet a Native person, and it was a non-Native lady with that was sitting, and she goes, oh, you will. You'll see a lot of Native people. And I was like, yeah, right, you know. And we got off the plane, and everything in the airport was very Native, very Alaskan, and it was just, it was so pretty, and every person that I saw had some kind of heritage background, some kind of, I would have to say Native, but I don't know, maybe they weren't. But it was really cool to see that, and then I thought, why are you guys bringing me up here? You have like amazing people that work up here and live up here. But what happened was because they weren't colonized like how we were, nobody went up to Alaska to take away land and things like that, take away your culture or your anything like that. They got to keep a lot of that. So a lot of them are still instilled in that. And with the state work that we've been doing here in Montana and the collaboration that's what they wanted to hear about. How does somebody go into the villages that's never been in the villages and build trust? So that's what they wanted to learn about. And I said, first of all, you need to invite somebody from the village to you, and you need to make some time. So it's always harder to say that because it's really scary from, you know, if I told somebody, well, just go down to Crow, it's fine. And if they've never been to Crow, they would probably say, oh, I don't want to go there. So it's nice to take somebody along that you know, and then it breaks down a lot of barriers. It's not easy, but it's also not that hard. So Indian Health Service. Like I said, I never worked in Indian Health Service. I'm just a baby brat of workers that work there. So, you know, this was a federal treaty that was signed, and it was supposed to make sure that we receive free health care for as long as possible, right? And we see that no matter what type of health care you're talking about, we're always in despair. Because why? Because technology is always growing. Therefore, we're always learning more about a disease, better treatment for that disease. So we're always growing, so there's always going to be disparities. IHS doesn't have the budget to grow to learn and to provide the equipment in those facilities to make sure that we're growing with the healthcare system outside of IHS. So that's where those health disparities exist, because it's the same, same people. And then you have somebody, I think of my mom a lot in this, because she, even though she was a human resource specialist for IHS, that doesn't mean she was a healthcare provider. She wasn't a nurse. She wasn't an educator. She looked at compliance all the time. That's what she looked at. She looked at federal regulation and law and all that stuff. She was a smoker. That's how she looked at all her manuscripts, and she would sit there and smoke all day. And back when I was a kid, I'd go visit my mom at IHS on Central Avenue, and I'd go visit my mom, and she'd be smoking at her desk at an IHS facility. And she always jokes about it, with their ashtrays all over at IHS. So it's nice to see how much has changed, and that we don't allow smoking in a lot of places. But she didn't like to access health care, because when her mom went to go to health care, her mom became diabetic. And then her mom got sick. All of a sudden, mom's sick. So she didn't look at healthcare like it was a good thing. When she went to the dentist, she got her teeth pulled. That was the first time she went. So her teeth were so rotten that they had to pull them when she was a little kid. So she didn't like going to the dentist. She went to an eye doctor, and she had a different ailment in her eye that a regular optometrist couldn't fix. So he said, "You're mentally retarded and we can't fix it." And she was like, she was a little kid. What she had was a lazy eye. It was, there was nothing that could be corrected other than glasses. And so, but the optometrist just told her that, and they told my grandma. And so, when you're a kid and you hear that, so then you lose trust. And so she never looked at healthcare as anything glamorous or fancy. And then her daughter goes into healthcare and wants to start the world on fire with prevention. And I talked about PAPs and mammograms, and I thought it was so exciting. And it was a lady in Crow. She was an older lady, and I called her and I said, "Oh, are you going to call and schedule your PAP and mammogram today?" I was all happy, and she said, "Who the hell do you think you are, and who the hell do you think you're talking to?" And she started cussing me out. I hung up the phone, I started to cry. And then my coworker said, "What's wrong?" And I'm brand new, just came out of college, thought what I was doing was so great. And I said, I just asked her if she wanted a PAP and mammogram. And then I was like, oh, I just asked her to get a PAP and mammogram. I realized what body parts I was talking about. I wasn't just talking about, oh, we're going to save your life, or we're going to help save you from something. I was talking nasty to her. So I was like, oh yeah, well maybe I should change it up a little bit. So I took that energy, and instead of quitting and letting that affect my outlook on it, what I said was, we're here, I'm calling to schedule your wellness exams. Because there was another word I wasn't allowed to say, was cancer. Don't say cancer, because if you're looking for cancer, you're going to find it. That's taboo, that's something that we believe in. So then I was like, okay, we're going to call it cancer screening, or not call it cancer screening, we're going to call it wellness exams. So then that's how I changed it. And we still have our bingo events down at Crow and Lame Dare. The lovely ladies down there still get super excited, line up for the whole day to come to bingo to learn about breast cancer. But nobody knows that that's what they're coming for. Because health fairs, who goes to health fairs? Healthy people. So you're trying to educate people that probably already know what you're going to talk about. So at a bingo, it's a fun way to say, let's talk about some of these difficult things. Let's talk about behavior change, health change, without making it sound like it's a lecture. It needs to be fun. It needs to be a way to interact with the people that you're serving. So by me doing that, I started bringing my mom and my grandma, and my mom is now smoke-free, tobacco-free for 4 years. I never thought I'd ever see the day. And now she says, I go to my doctor because they're going to tell me something good. Now I feel like I'm going to school and then I get a good report card. So it took a long time from my own mom that worked in healthcare that is native, that saw health disparities come through IHS. And she had to go through that through her whole lifetime. And now she's living a healthy life, and she's doing really good. So sometimes we give IHS a bad rap, but we don't really look at the whole picture of what you're dealing with. So partnerships do exist with IHS. Sometimes it feels like it's unreachable, unattainable. It's a lot easier. What's difficult is because the people working at IHS and the ones that are going to be your go-getters, they're the ones that are go-getting at everything. So it's hard to nail them down and maybe work with them. But then after you nail them down and say, well, who should I work with? Who would actually help me with this? What should I do? And most likely they'll point you in the right direction, and it's not going to be the first time. You have to be very consistent. You have to not have to be buggy, but you just have to show up and visit a couple times, and you have to make time. So it may not be worthwhile in the beginning, but overall it'll start paying off. And like I said, relationship building, maybe not just coming to talk to them about PAPs and mammograms, maybe start talking about other things. Talk about the services that you can bring to the table, not just what they can do for you. And then for St. B's, what we did was we provided training and education in the ERs. So we took out our simulation mannequin and we went out and taught around pediatric education. So, and that's still going on. So structural determinants of health. So there's the free housing that I was talking about. And then our grocery stores. So this trailer that's down here, you know, we would assume inside that trailer is really bad. It's, you know, it's not healthy to go in, and especially if you're going as a home visit and you're going to check on a brand new baby. Your assumption pulling up is like, oh, good Lord, please watch over me. I don't want to sit on anything, and you already kind of have this. Well, you step inside and it's nice, it's organized, it's clean. So, you know, don't judge a book by its cover. So there's people in there, or it could be vice versa. It could look like a really okay house, and then you go in and then you're scared to sit down. So, you know, just going in to prepare yourself to make sure that your body language isn't like, you know. But this could happen at anybody's home, right? At any home visiting, regardless of the background of the person. This could happen anywhere. But let's try not to assume just because they're native that it's going to look like that. That's really where the flip-flop is. And then our grocery stores, Lame Deer's doing a really good job. They have fresh produce now, and does Crow have a little bit? And we have to think about that too, because in our rural stores, so Harlem, Montana, does anybody know where that is? That's right with Fort Belknap. So we had to go all the way to Great Falls to get like our fresh fruits and vegetables. You know, I just talked to my mother-in-law this past weekend, and she's starting to go to Lewistown because nothing in Harlem is fresh. And she said as soon as you get it, by the time you get home, it's bad. So we have to think about the resources that we have. Nobody's going to go out of their way to go provide fresh fruits and vegetables in these rural places. And number one, that's probably going to cost quite a bit. So when we talk about nutrition and diet with our patients, we have to ask them, instead of saying eat this, this, and this, maybe we can say, what is it that you like to eat? What is it that you have access to? Instead of putting more onto their plate that they won't ever be able to do anyway.
Excuse me, is there any movement at all? I know in a lot of lower income areas there's a move towards community gardens to kind of grow the stuff there so it is fresh and there's buy-in.
Yeah.
Has there been any success doing that sort of thing in the communities as well?
Yeah, I know in Fort Belknap they have, and like I said, I don't know about Crow College, like are they trying to do a garden? So I know a lot of the colleges, it's kind of like linked on to education, but in Fort Belknap what they're doing is it's right at the college, and then in Lodgepole, which is like 30 miles south of Fort Belknap, so it's the same reservation, it's just a different community. They're building a store there where they're going to have all game meat and all fresh and natural fruits and vegetables. So And then it's like, okay, now you have the resource and you have the goods, are people gonna use it?
Yeah, the food desert thing is a hard
Yeah.
thing to overcome.
Yeah, so that's, and I hope we'll see a change, because we're seeing too many kids that are obese, you know, in all populations. So it'd be really nice if we can see a change there, instead of just the, you know, this is, at our ceremonial gatherings too, they've been encouraging more people to bring in, not chips, like more fruits and vegetables, because really, if it's ceremonial and traditional, they didn't have Doritos back then. So.
I was seeing a difference in a grocery store in Poplar.
Oh.
And or one that's not close to a reservation. How they stock the shelves and what they put on them is very different based on what they've learned to eat, because they couldn't put other things. So
Yeah.
that also changes things.
Yeah.
And they also work closely with the schools where children attend, so that there's more service and teaching related to things like that. So more
Yes. Yeah, a lot of education. So our structural determinants of health, you know, sometimes when our patient comes in, we think we're gonna help them in this little piece of the pie that they're coming in for. But really, maybe they don't have safety in their home, maybe they don't have running water. So, you know, when we have to be mindful of what we're talking to them about and not adding on more stress. So American Indian families, and I use American Indian a lot. I like to use Native, but for grant languages, American Indian is what works. So, barriers and challenges to obtaining care. So, like what we talked about, access to care. Like I said, geography. Maybe they already do have a vehicle to come up to Billings in, but because they're the sole provider in their household, they have to also manage other things. So that is their time, right? Our time and somebody else's time is totally different. So this past New Year's Eve, we went up to Colbert. Where did we go? Scobie, Montana. Does anybody know where Scobie, Montana is? So we went there for a basketball tournament, and I said just being there made it feel like time stood still, because we're used to living in Billings and used to being busy, and you know, so it felt like time stood still, but they were doing their thing. So like the time between rural and then also within the work that you do is also different. Like I said, ER's time and inpatient time is different. The way that they manage their time and the way that they utilize time is different. And resources. So when I talk about this, I used to talk about this in a way that we utilize all these resources, but really what it is we have a small community that needs a lot of resources, therefore the resources get spread thin. So it makes it very difficult. So like when I lived in Fort Belknap, the people next door to me didn't have much, but either did my dad and I. But the difference between them and my dad and I was we knew how to ask for what we needed. That was the difference. Because we lived in Billings before, because my dad, you know, was educated or whatever, he knew to ask for certain things. So if the plumbing went out, he knew to go talk to a plumber. If the electricity went out, he knew to go talk to the electrician. But on our reservations, we have a housing department. And so it just, you know, it's knowing where to go and how to ask for it. Sometimes we assume that people know how to ask for what they need. Family and community involvement and compassion fatigue. You'll see this a lot in those that are taking care of their family. The ones taking care of their family also need help, because they're the ones that will actually refuse it or not want it because they're so worried about their family members or worried about the rest of their family. I got to see this a lot in working in women's health, because our women, we really do a lot in our families, regardless of any tribes. I see Native women, because I'm a Native woman too, so I can say that. But our women do a lot, and so they sometimes forget about themselves. And so when I look at our families, sometimes we just look at that individual client, but there's a support system behind them, or somebody that might be enabling them or triggering things. So it's really good to involve family. The holistic approach, and again, I talked about the difference between our spirituality. Some of us were raised Catholic, some of us weren't. But to incorporate that and to allow them to talk about it, because it will be a good resource for them. Communication. We use our hands a lot. I know in a lot of cultural sensitivity trainings before 2000 was you don't look natives directly in the eye. I think I looked at everybody in this room, but I'm only one native. I can't say, oh, every native is going to be like that. Our older population, they look down a lot out of a sign of respect. Our spiritual care team at the hospital said, you know, Native people don't look at me. And I said, well, you're a pastor. They hold you in a high regard. They don't want to look you in the eye. It's out of respect for you. It's not really so much about us. Or sometimes we're hard of hearing, so we want to hear better. Or especially, like I said, if it's a bad diagnosis, we look down because we're just trying to take it all in. I don't want to read your body language because your body language is freaking me out. So I'm going to listen to how your voice is. I'm going to listen if there's any hope in that voice, or maybe I'm trying to shut down too. So it's hard to say historically this is how it is because we've also been incorporated with other cultures as well. And we have some kids that were raised solely in foster care, so we can't say, oh, they're doing that because they're Native. Well, they might be doing that because they're shutting down. So, you know, we can't just always assume. I'll talk about that all the way through, assuming. And then fear, that's instilled in us. Like I said before, things were taken away from us so fast. And that fear comes from that historical and cultural, historical and generational trauma. And again, that's a whole nother lunch and learn.
Kassie, how much of it is individualized approach versus tribal and separate? Separate culture?
I would always approach it as an individual. I think it's too heavy to make, like I said, you can't just say, oh, you're pro, so we're going to do this, or, you know. And this is the way it is, too, because remember when I talked about pedigree earlier? So it makes it harder to marry somebody, too, because we're all related. Because that blood can only go for so long, right? Before you start marrying your cousins. And so, like myself, I'm married to somebody that is not of my tribe. And so my kids have 5 different tribes in them. And so for my little person to go into a pediatric doctor and then they'll say, well, you're enrolled Northern Cheyenne, but spiritually you're being raised as a white clay, but then you have a Cree and a Assiniboine background, so what do we do? That's too heavy to put on a provider. But instead, understanding that they're Native American and maybe just understanding there may be differences. Not differences that make it difficult, but differences that you may be able to incorporate to make sure that your care plan is played out. So I think individualizing it is better than assuming that they're all together as one tribe. So what you'll encounter is shy, apprehensive, fearful, lack of health literacy, family either very involved or not involved, lack of trust, and time. So like I said, my encounter working with Native women and talking about have some mammograms, I got a lot of this. Not only did they make eye contact with me, but those grandmas made me feel really bad for talking about pap mammograms. But I found out, you know, we cross our arms a lot, Natives, we do. I'm surprised you ladies aren't doing it. Did I make you do it? Did I make you do it? But this doesn't mean we're mad, you know, but I always say the scariest thing you'll encounter is that the grandma. My husband's here today, so I get to make fun of him a little bit, but our Native men are a little bit easier to work with. They're more lighthearted, but as with Indian women, we just have a wall around us that we don't want anybody a part of, or we don't want anybody in. And so it's a little bit difficult working with our Native women sometimes. We're very guarded. For whatever reason that is. If I knew all the reasons, I wish I could tell you. But, so again, there is a gender difference. There's a Native man talking about American Indian Patient-Centered care would be different. But we are shy until you get to talking to us, and then we'll talk. As long as we have something to talk about, we'll talk. but it takes a while, so it may not even happen that first visit. Like I said, you only get 15 or 20 minutes with them. What are you going to do in that time? Today I was at my son's school at Riverside, and you know, the kids are coming in like they were so tired and life is so hard, you know, because they're teenagers. And I wasn't getting anything off of them. They were just like, they were like, whatever, we're done. We don't want to hear any more about any careers. And I was showing one of the kids, you know, a patient interaction. So I said, at my job, I get to say, hey Barb, how's it going? That's a good interaction, right? But if I come in and, how was your stool today? Your arm's gonna be crossed. You know, you didn't even give me anything to open up with, you know, like instead, hi Barb, how's it going? How's your day? Geez, it's really nice outside. Did you find this place okay? Well, good, I'm glad you're here. Let's talk about what's going on. So that's what I get to do at my job. I get to help our providers build a rapport with their patients. Now, again, if we have surgeons that never get to talk to their providers, it makes it a little bit, or to their patients, it makes it a little bit difficult. But sometimes we forget, especially when I was talking to the 6th and 7th graders today, what we were taught as kindergartners, right? You treat everybody nice. You know, regardless of what your profession is, regardless of how that patient, you know, is coming in, whatever's going on, we do our best to treat each other with respect. So that's what I get to talk about. And sometimes, like when I talk about history and the historical and cultural trauma, that stuff is really heavy. It's too heavy to try to accomplish breaking down barriers in 15 minutes. And it's impossible. It's impossible to know about every single tribe. It'd be unrealistic to say, oh, this is the characteristics of each individual tribe and this is the outcome. That's unrealistic for me to assume that you guys would learn that or even want to learn that. So that's why we just talk about, these are some of the characteristics, these are some of the encounters that I have. These are some of the things that are some solutions for that. So introductions, like I said, you know, shaking hands, and greet all family members, because especially in the hospital, I get this a lot. How come there's always so many family members? Well, one, we're nosy. I'm kidding. We really care about each other. So I always ask this question, how many people have talked to their brother or sister today? If we were somewhere, you know, like our native people, like they'd all be raising their hands. Because we live within our community. None of us have really moved away, and if we have, even if we moved away, we still talk to each other on a daily basis. We have aunties and uncles. So how it is our first cousins are our brothers and sisters. And then so if you're raised as brother and sisters with your first cousin, and then they have kids, so then you're probably raised as brother and sister again. So by the time you're a cousin, you're like 5th or 6th cousin. So how many people know their 5th or 6th cousin? I do. I have to, so I don't kiss them. But that's why our families are so tight and so closely knitted together, because we are raised with each other, not just raised with each other, but we love each other like brother and sister. Our aunties and uncles are an offset of our parents. So if you don't have parents anymore, you go to your auntie and uncle. And if you don't want to listen to what your mom has to say, you go to your aunt. So that's why we are so close. And that's why when our NICU families, our NICU nurses said, how are we supposed to tell who's the real grandma? Because when they come, they say, I'm the grandma. And then there's like 5 grandmas saying, I'm the grandma. And so I always say, you know, ask the patient to say, these are who can come in, and this is the time limit. The one good thing about our culture, as much as we don't want to say it, we are really good with protocol and procedure. We really are. That's an elder, they eat first. We're used to protocol, we're used to procedures. So as long as it's said appropriately and not like, well, because you're Indian, you can't have all your family here. You know? And that's not really what is said, but you guys have a lot of family. You guys can't come in here. There's a way of saying things without making it sound like it's because you're Native, you know? Because when you are Native, I've never been anything else in my life, I've only been Native. But when you are Native, when something comes at you like that, the only thing that goes in your mind is, oh, they're doing that to me because I'm Native. That's the first thing. But you're not coming at me that way. You're just following the rules of the hospital, or you're just doing what you need to do. So just maybe just saying it, referencing, say it in your head before you say it out loud. Diagrams and visualization. My daughter was diagnosed with asthma, and I thought I just knew everything because I was a health educator. And then my mother-in-law was like, let her cry a little bit, and that'll build up her lungs. And then she got really sick, and you know, and we didn't realize that giving her breathing treatments was actually making her stronger. And we didn't understand her full diagnosis until we went to the specialist, and then they showed us the diagram of her lungs, and then she said it's like saran wrap and put water in there and you're trying to separate it. That's her lungs. But by giving her that medication, it opens her up and then it helps her breathe better. And I was like, oh. So it helped me understand. So just because, and same as me, I'm a health educator, but I don't go in, you know, I'm with my baby, and they don't know I'm a health educator or anything like that. But it was really helpful for me the way that they taught me, and I didn't feel like it was condescending at all, that they really cared about what my thoughts and feelings were after diagnosis. And healing stories. A lot of times, you know, when you're given a diagnosis, it hurts you to your core. But if you follow it up and say, your daughter has asthma, and she's probably going to be sick for a little bit, but as long as you're doing the medication the way that we say, and doing the things that you guys like to do, and staying active and things like that, by the time she's 5 years old, she'll grow out of it. Well, she's 2. I didn't want to hear about when she was 5 and all the work that we had to do. But because he told me by the time she's 5, she'll grow out of it as long as you do these things, A, B, and C. And now she's 8 years old and raising cane like anybody else and completely off medication. So we did it. But it was good to hear that, you know, just because this diagnosis is for the moment, you don't have to be stuck there. We need to follow it up with something healthy, or, hey, I had another patient just like this, or, you know, you don't have custody of your kids right now. I understand that's really difficult, and it's going to be even more difficult going to all these classes, but you know what, we're here for you. Whatever questions you have, we're here for you. I'm not, you know, don't show that judging or criticizing, because they're already feeling that. So introductions, like I did with Barb, you know, shaking hands, you know, greeting yourself, or maybe say, hey, I see that you're from Fort Belknap, Montana. Well, I'm from Malta. You know, you don't have to make up that you're from Malta, but you know, like, oh, you're from a small town. I'm from a small town. Wow, that's pretty cool. You know, like something that would, you know, get them to talk about it. So these are my kiddos. So the one in the middle was the one I was just telling the story about, Ivy. She is laughing and playing and having a good time. And my daughter, Abilene, my son, Cactus, and then my other sons. These are my nephews, but they're my sons, Kason and Caleb. And so, and we're all really close and pretty tight. So organizational solutions. Knowing the community and the people in that community. Incorporate trainings and teachings and regular staff meetings. So a lot of times we incorporate a lot of American Indian education and training during November. Just like February, you know, we talk a lot about African American Heritage Month, and it makes it easier to talk about, right, because we're celebrating that month. But what I encourage is that you incorporate some kind of cultural training in every staff meeting. It could be as simple as a story. It's a way to change your thinking. And that's what I'm asking, is just change your thinking, assumptions, and stereotypes. Just change them. And that's why I said it needs to be frequent and consistent, because sometimes we really make it so beautiful and magical, you know, when we're celebrating a Heritage Month, but sometimes there's no beauty in it. Sometimes it's really difficult to talk about things. You know, like I really have a prejudice over people that don't take a shower every day. And to say that in a staff meeting, like, how do I get over that? How do I get over, you know, sitting down with somebody that doesn't look like they have it together? Or, you know, like, right now we're working on a grant at St. Mary's, and it's a prenatal substance abuse grant. I myself had a hard time. I went to my supervisor and I said, I don't know if I could do this. I don't know if I could sit down with the mom and say everything's gonna be all right when her baby is addicted to a substance. And then she said, well, just go home and think about it, and I'll try to answer your questions tomorrow, but don't feel overwhelmed today. Because I went through the NICU, and there was a baby in there that needed help and support. And so I wasn't up face and front with it when we were talking about it, but then there was a baby needing extra support. When I went home and I thought about it, I was like, wow, that baby's gonna be there probably for about 3 months. And they have 24 hours, 7 days a week of care. And that mom has nothing. That made me change my outlook on it a little bit. That she also needs intensive care. And that intensive care could be as simple as going up and telling her, when you're ready, we're here for you. And I didn't learn about that until I talked with Rimrock Foundation. And I got to meet with one of their addiction counselors. And she said, oh, there'll be people that turn you away, Kassie. Because that's a whole nother culture, right? Addiction and substance abuse is a whole nother culture. That it's not the Native American culture. But unfortunately, a lot of our providers only see the results of both, right? And so she said, just be patient and offer support, and then see what happens. So that made me change the way I thought about everything. You know, some people don't have a choice. That is their only choice. So to think about that in their terms, we have many choices and we look at choices in a different way. But some people just don't have choices. So that made me think about it a little bit more. So again, just bringing it into your staff trainings and making it open for your staff to talk about it. Because a lot of times when you have these biases and it's all by yourself and you're trying to get yourself out of it, or you're the only one, and I'm not saying, you know, interactions are perfect. I'm sure you've had an encounter where it wasn't perfect with a Native person. I can almost guarantee it. But not every Native person is that Native person. And then on the flip side of it, I try to tell my family, not every white person is that one white person that hurt you. So it's that flip-flop a little bit. So, any questions?
Kassie, what do you do in a situation where, you know, you have a structured day? Mm-hmm. You have appointment at this hour, this hour, this hour, and your client is coming in late or not till later in the afternoon. How do you respond to that in a sensitive way,
Sure.
but still have to make your day run?
Yep, I know that one's difficult. We had one of our diabetes outreach, it was wound care. She came to me and she said, every Native person that I have is showing up late, what do I do? I was like, well, I don't know, you know. I don't know. And I said, well, how about you track and see which ones it is? Maybe it's transportation from Crow, or maybe it's transportation from Lame Deer. Maybe it's a transportation issue on their part. Let's try to figure it out, because it was wound care, so they were coming in once a week. Come to find out, it was one Native patient and they were in town. Transportation was on time every time, but this Native patient, there's a lot to be said with diabetes and chronic care, right? Sometimes one day they decide to care and one day they decide not to. So it was really about the illness and not the person. And so that's what I could probably tell you, is try to map out maybe which client it is, or maybe where they're coming from. You know, what I always say is, don't make your appointments at 9 a.m. if they're coming from Crow and Lame Deer. You know, I mean, we think no big deal, but you know, it's a long way. Especially for transportation, you know, and building a good rapport with your transportation. There's a good rapport with the transportation with the diabetes and stuff like that, but unfortunately, if you're not diabetic, most of the time you're not gonna get a ride up on the diabetes van. But then the other side of that too is, it comes along the line of respect, and dysfunctional people, regardless of what background they are, don't understand respect. So, I think letters and even posting it and saying, you know, or maybe the next time they come to you and say, you know, I noticed that you're not coming in on the scheduled time, is there a reason for that? And then let them answer. If they really don't know, then sometimes you just have to suffer through it. Yeah, I know, it's hard, and I wish I had.
Sometimes you feel real bad, you know, they've come a long way, but you just don't have any place to put them.
Yeah.
And I think the idea of, you know, making it later in the day so there's a better chance that they'll make it to town in time and that sort of thing. But yeah, because you feel bad, you know, you want to help these people, but there's only, you also have the other people who are sitting in the waiting room who are here for their appointment.
And I don't know if you can do this. If the appointment is at 2, go ahead and say it's at 1:30.
I have no problem with that.
Okay. Yeah.
I do that. That's not a cultural thing.
Yeah,
That's just a people thing.
It is, but then sometimes you get a really good person and they show up at 1:20 and then they're like, my appointment is at 2 and you're making me sit out here for. So, you know, I think it's just working with that client, maybe monitoring which client
Who
is
it
coming
is.
in late.
Yeah.
Yeah. So, I didn't mean to keep you guys over, I just now looked at the time, so. Yeah,
We're not shocked.
Yeah, take my information down. A lot of times I know that things pop into your mind later on, and I have no problem with following up with questions, or, you know, sometimes there's that weird situation. So, and I don't mind, because I may say, I'm gonna go ask a few people, and then I'll get back to you, so.
Thank you, Kassie.
Yeah,
Thank you.
Thank you.